We shall be discussing a very short topic from your thyroid, which is your thyroiditis. Usually you get a one-liner based MCQs from it, or it could be a clinical based scenarios on the basis of this one-liner. So we shall be discussing the thyroiditis mainly as one-liner questions, right? So first we have your chronic lymphocytic thyroiditis. So it is because of the raised titer of thyroid antibody, which is TPO antibody and TGA antibody, right. Then it causes a diffuse and a nodular characteristic bosselated feel of the thyroid gland. It is associated with toxic goiter, much more common in female compared to male. It is associated with an increased risk of your papillary carcinoma. Now, it is the most common type of your autoimmune thyroiditis. The cytological features of your Hashimoto's thyroiditis include your aggregate of lymphofollicular cell with Hurtle cell changes, minimal colloid, infiltration of mature lymphocytes, giant cell, plasma cell, macrophages, histiocytes may be seen. Now, they may also be associated with your primary thyroid lymphoma. Now, the second most common type of your autoimmune thyroiditis is your postpartum thyroiditis. It is present in approximately around 10% of women, occurring around 2 to 12 months. Now, it is short lived and it resolves around 2 to 4 months, right. And the treatment would include a short course exogenous thyroid hormone supplementation or replacement may be necessary. Now, this is a histopathological image of your autoimmune thyroiditis, where you can see that there is intense lymphocytic plasma cell infiltration as well as your acidic destruction and fibrosis. Now, moving down to the next thyroiditis type is your Riedel's thyroiditis. So, these are conditions where your thyroid tissue is replaced by fibrosis. It is said to be a collagen disease. It is usually painless, right, and it may be unilateral or bilateral and is hard and fixed, since it has been replaced by the thyroid tissue has been replaced by fibrosis. Now, the treatment part over here would include your high dose steroid, tamoxifen and thyroid replacement. Then we have your granulomatous or the subacute or the decurrent type of thyroiditis. So, it is usually following a viral infection, presence with pain in neck or fever, malaise and firm irregular enlargement. You find over here a raised inflammatory markers. Then there is absent thyroid antibody differentiating it from the autoimmune thyroiditis. Then the iodine 23 uptake is low. It is usually self-limiting. Treatment part, we use prednisolone and thyroxine if your thyroid failure is prominent, right. It has a female preponderance, most commonly occurring in your 4th decade of life, and it is associated with your transient hyperthyroidism followed by hypothyroidism. And in cytology we find nucleated giant cell granulomas, right. And then last form of thyroiditis is your acute suppurative thyroiditis, the most common cause being the infection of the congenital pyriform sinus fistula, and the most common organisms implicated in it are your staphylococcus and your streptococcus species.